A warm welcome to everyone who has zoomed into this webinar. World Suicide Prevention Day is an awareness day observed on 10th September every year since 2003 to provide worldwide commitment and action to prevent suicides. The IASP collaborates with the WHO to spread awareness around the world. Sumithrayo has organized 4 webinars during the month of September, and this is the first. Joining us today to share her knowledge and thoughts is Dr. Suhashini Ratnatunga, consultant psychiatrist at the National Hospital of Sri Lanka, honorary consultant psychiatrist to the Sri Lanka Air Force, and senior lecturer at the Faculty of Medicine, University of Colombo. Welcome, Dr. Ratnatunga.
Thank you, Jomo, and thank you for the invitation.
The theme this year is creating hope through action, which encourages all of us to consider the role that offering support may play in combating suicide. We are all part of a community, linked to family, friends, work colleagues, neighbors, or teams. Sometimes we become isolated and disconnected from our communities. Social connectedness reduces the risk of suicide. So being there for someone who has become disconnected can be a life-saving act. We have the responsibility to support and empower those who become vulnerable in our communities. So if you are worried about someone in your community, reach out and ask them, are you okay? By simply checking in with them and offering non-judgmental support, you can make a difference. It is important to know that people in distress are often not looking for specific advice, but merely to be listened to with compassion and empathy. At Sumithrayo, barriers such as class, race, and religion, political or sexual leanings are non-existent. Every caller will be provided with emotional support in an atmosphere of total confidentiality. The service provided is completely free, devoted to responding to people in crisis and preventing suicide, focusing on empathetic, active listening and non-judgmental responses. Sumithrayo volunteers endeavor to take every person in crisis seriously. The goal of their befriending is to empower the caller to make life-enhancing choices. Our mission is to help people choose to live and not choose to die. Sumithrayo, confidential emotional support from people who care. A free service open 365 days of the year from 9 a.m. to 8 p.m., including holidays. So let's start off interacting with Dr. Ratnatunga. Doctor, there may be some confusion between... Doctor, you can hear me?
Yes, loud and clear. And thank you, Jomo. I think you made life very easy for me. Everything was said basically in a nutshell.
Right. It needs to be
Yes, let's elaborate further. Okay.
Okay. So, Doctor, there may be some confusion between deliberate self-harm and suicide. The most significant difference between suicide and self-harm is the intent. That's what I feel. Right. While suicide attempts usually come from a place of despair, hopelessness, and worthlessness, self-harm is a way to cope with feelings and stresses. For some, the pain from self-injury reassures them that they are still in fact alive, especially when they're experiencing emotional numbness or disconnect from the world. But people who repeatedly self-harm can become desensitized to pain and may accidentally suicide or even view a suicide attempt as less frightening. Doctor, can you share your thoughts on this and on how important it is that every person who self-harms be assessed for suicide risk with follow-up care?
Right, okay. Let's just, I'll very briefly talk about the 3 main differences between suicide, suicide attempt, and deliberate self-harm. So suicide is a very unusual phenomenon, which is actually seen only amongst humans in the animal kingdom. There have been some reports amongst animals, but still we are yet to verify those reports. But as far as we know, suicide is only described amongst humans. Suicide is considered a fatal act, okay, of self-injury, which is undertaken consciously, where the patient himself or herself wants to end their life. So it has a self-destructive intention. When we talk about a suicide attempt, that means when the person actually survives an act done with suicide intent, a self-destructive intent, and that is called an attempted suicide. Then this new concept of deliberate self-harm, not a new concept, but something now we talk about a lot, because deliberate self-harm is now becoming very common in Sri Lanka, is a behavior in which people deliberately harm themselves, cutting themselves, taking overdoses, right? But they do it but the end result is a non-fatal outcome. So those are the three main differences. When we talk about a suicide risk assessment, long time ago, there was a lot of excitement with people developing rating scales to assess suicide risk. There is no superior rating scale than a clinician assessing a patient with suicidal intention. Okay, so can you hear me? It's raining cats and dogs here.
Can. Loud and clear.
Right, okay. So what I'm trying to highlight here is there are lots of rating scales which are used mainly for research purposes, but no rating scale will trump an assessment done by a mental health professional to assess suicide risk. So even if I get a patient coming with a rating scale saying his suicide risk is low, during my assessment and my interview, if I deem that this patient's suicide risk is high, I can basically throw away that assessment scale. So when we talk about a risk assessment in suicide, there are lots of factors we consider to come to a conclusion as to whether this patient is high risk, moderate risk, or low risk. Do you want me to talk about those risk factors here, or shall we talk about it later?
I was just wondering, doctor, now when somebody self-harms, they are probably entered into an ETU or something. So can those first responders also be able to assess to some degree at least, or push them towards another professional? What would normally happen?
What would normally happen is when a patient is brought to hospital following a deliberate self-harm attempt, after initial medical stabilization, a psychiatric evaluation is done in hospitals where there are psychiatrists. So especially in Sri Lanka, all the teaching hospitals and the major general hospitals, government hospitals, and most private hospitals will have a psychiatrist. So a psychiatrist will come not immediately. Once the patient is medically stable, will come and do a risk assessment. And after the risk assessment, the psychiatrist will come to a conclusion as to whether the patient is high risk or low risk.
Okay, I understand that. Thank you so much for that. Anything else that you need to add, doctor?
At some point in this webinar, we need to discuss about the risk factors.
Yes.
How we assess a patient to be of high risk or low risk, that we can do.
Yes, I'll give you that opportunity in one of those questions so that we could delve into that too. So I hope everybody is very clear now between the distinction between self-harm and deliberate self-harm and suicide. I think there's a thin red line, but it all depends on the intent. Doctor, am I right in that? That it's
That's
the intent that really matters.
Yes, in deliberate self-harm, patients can have lots of motives. In suicide or suicidal attempt, the patient has one motive: to end their life. But in deliberate self-harm, it can be a cry for help, expression of distress, demonstrating distress,
yes,
relief from a terrible state of mind, change or to manipulate others to get one's way. So there can be lots of other intentions.
Yes. And doctor, also, when self-harm is done repeatedly by a person, the body could kind of develop tolerance to the pain. Am I right? Which might, push that person to self-harm harder and harder.
What we do know is if a patient has a past history of self-harm, and the patient is now coming with another self-harm attempt, their risk of suicide is considered high. Because people who have self-harmed previously are likely to do it again. But we also know, which you mentioned in your introduction, that there is a category of patients who can die accidentally, where their intention was actually not to die.
Yes.
But by a certain method used, there is death by misadventure, some people call it, or accidental death.
Okay, I understand. Thank you so much. I'll kind of move into the second interaction with you. Suicide is often the result of a culturally embedded response to interpersonal disputes, arguments between spouses, parents, and children. failed love affairs, extramarital affairs, and failed examinations and job opportunities are also frequently cited. In many cases, shame is recognized as a leading cause of suicide. It can be said that a deficit of emotional intelligence, poor coping skills, and resilience can also be the cause. Doctor, how can stakeholders and gatekeepers help people to acquire life skills to help them navigate and survive such moments of impulsiveness?
Yes, good question. Well, I think one of the things we need to identify is one of the protective personality traits like resilience, positive coping strategies. All these are found to be protective factors when it comes to suicide. Also, interpersonal skills. We know, I mean, there is evidence to say that societies with very tight community connections, tightly a sense of community, people who have a lot of interpersonal skills or stable relationships are also considered protective factors when it comes to suicide. And in our preventive methods, we use these a lot. Apart from this, there are, when we take adolescents, young children, and late teens, between the ages of 10 to 19 is what we consider a very important age group where socio and emotional life skills are learned. Basically, children and adolescents learn this from adults and their immediate caregivers and teachers. So this is actually a very critical period for the acquisition of life skills. And also we know this is also a critical period where we see the onset of mental illness. This is the time disorders like depression, anxiety starts. This is the age we start seeing them. So basically, mental health awareness to reduce stigma and to improve help seeking during this age group, in this time period, is very important. And also in schools, we need to start life skills to emotional well-being, talking about their emotions, socio-emotional well-being, problem-solving techniques, coping at times of stress. Again, there is evidence to say that micro-stressors during childhood and adolescence builds resilience. So I guess as parents, we don't want our children to encounter danger. We want them to have an extremely happy childhood and protect them from everything. But this can actually go against them, against their personality building. So too much shelter, nothing grows under a tree, basically, under the shade, basically, okay? So, I mean, exposing children to, certain, allowing them challenges, giving them the independence to face certain life challenges without us kind of interfering too much will also help them build resilience. So when they come to adulthood and when they're actually faced with proper life stresses, some of these young adults are unable to handle them because they have been sheltered so much, protected so much as adolescents. And in our school curriculum, I mean, we have a very good educational system, but our education is not geared to improve our children's social well-being and emotional well-being. So programs to improve the positive mental health of children is also something we really need to talk about and focus on.
Yes, thanks, Dr. There's two things I like to talk about. One is that the fact that the young people of today are constantly engaging in social media and maybe even evaluating themselves, and it can affect their self-worth, their self-esteem, and as a result, they are not given that opportunity that you spoke about of facing real life situations and and it's, I think, very importantly, resilience is the most important thing to possess in a human being, to be able to come out of things on your own rather than self-diagnosing and rushing to doctors or whatever. That's one thing. And the other thing I want to tell you is that in 1995, when Sri Lanka had the highest suicide rate, there was a presidential task force that was appointed. And Sumithrayo was a part of it. And one of the things that they decided on was to have a life skills in schools, life skills in their syllabus. And I think a textbook was also published. But doctor, unfortunately, when I make inquiries, students tell me that although there is a period, it is never discussed in schools. That's a very sad thing. One of the most important things which you have been talking about now, that the development of life skills is so important. And if policymakers are allowing it to, get behind them, it's very sad, isn't it?
Jomo, our students are exam driven. So it is first, our students are exam driven. It is the scholarship exam, then getting the 9 A's
Yeah.
for O levels, then
Yes.
getting the 3 A's to university. So their focus is on passing exams and not building life skills. In a way, you can't blame them also. So yeah, it's sad, but I mean, that again, when you mention social media can also be used in a positive way. Again, to create awareness, talk about mental health, identify people. I mean, we have identified certain patients who have relapsed purely by looking at their social media profiles. So, I mean, sometimes we use that to kind of identify, that, okay, this person is not doing too well now.
Yes.
Also, so as a result of social media, I mean, interactions have gone down. People, are chatting online and they don't meet physically. There's a lot of cyberbullying happening now. So there are two sides to the coin, but I'm sure social media also can be used to improve mental well-being. And since our students are now there is easy access to social media and they are very competent in using social media, this is something we need to think about and use social media as a positive influence.
Doctor, one more thing I like to add to what you said was that today the young people and also adults have too many choices on their mobile phones. I mean, that can make them anxious. So for instance, if they want to choose a film, there are hundreds and thousands of films to choose from. They don't know what to choose. When they choose one, they regret choosing that and then jump to the other. So do you think all these things can cause this, what people call attention deficit in them, where they are constantly navigating for other choices in their lives?
Spoiled for choice. Well, ADHD is a separate diagnosis. But again, we have seen children who are using devices a lot, especially small children who are on devices for a long period of time, do have attention problems. And now we are actually seeing almost an epidemic of this screen overuse, where parents bring their children saying, that they are not concentrating, they are not interested because there is TikTok, there is Instagram, there are lots of games, cyber games happening, and children are playing them. I mean, intercontinental games happening, so their sleep schedule is disrupted. They are up till 3 o'clock in the morning playing with other people in other countries. So all these have actually created a lot of anxiety, and we are seeing a depression as a result of screen overuse.
Okay, doctor. Thank you so much. That was very, very interesting to hear you talk about all of this.
Jono, just
Can you hear me, doctor?
Yes, clearly. Another footnote, when we were talking about resilience,
yes,
remember, as a country, we have been a very resilient nation. We have gone through the civil war, insurrection, tsunami, right? And I mean, as a community, as a population, we have demonstrated resilience.
Yeah.
And we haven't studied it. It's probably in our genes, but that is something to keep in mind, and that is something that we can work on in the new generation, in the
yes. And if people can be reminded that with resilience, they can overcome a lot of challenges in their lives instead of looking for support from medication as well as seeking help from the medical sector. So I'll just move on to the next question or the next interaction. There are myths surrounding suicides. One is that people who talk about suicide are not likely to attempt. Or another is that once a person has made an attempt, he or she is unlikely to make another. Or that people who threaten suicide are just seeking attention. and should not be taken seriously. Doctor, can you talk to us about these and other myths that keep popping up during discussions in our community?
Okay, one of the greatest myths when it comes to suicide is, and one reason why suicide has, well, there is an increase in less developed countries, is there is a myth that if we talk about suicide, or if I ask somebody if they're suicidal, okay, let me demonstrate this. Jomo, at this point, do you feel suicidal?
No, but I have felt suicidal.
Right, okay. Now, just by me asking you that question, do you think I put an idea of suicide into your head?
Not at all. In fact, I appreciated it.
Right, there you go. So that is what we are trying to say. So that is what people believe, that by asking about suicide, by talking about suicide, they are putting unnecessary ideas to their heads.
Yeah.
Right?
Shall I move on to the next question?
Okay.
But I'd like to just mention one thing, Doctor, because when you spoke about asking that question, suicide question, whether people will get upset. See, at Sumithrayo, when we talk to people, we have to ask that question. But the point is that we choose the correct time, the opportune moment to ask it. And it's about the tone of your voice. And when you do ask that question at that time, they're very comfortable. And it has to come at a certain point where they are probably talking about their pain and whatever it is. And when we put in the question at that time, they really appreciate it.
Yes,
I just wanted to add that at Sumithrayo, we're very sensitive about when to ask it and how to ask it.
Yeah, remember that question saves lives.
Yes. So, okay, thank you very much for those insights. The media also needs to reduce or eliminate altogether the sensationalism associated with suicide reporting that can act as a catalyst to influence the behavior of vulnerable people. They must avoid giving graphic details of the method used and avoid using words like commit, which makes it sound like a crime. Providing details of the mechanism and procedure used to carry out a suicide may lead to the imitation of suicidal behavior by others at risk. They can avoid simplistic explanations of suicide. They must encourage public understanding of the complexity of suicide. Above all, if suicide helpline is given at the end of the sub-report, it will help other vulnerable people with suicidal thoughts to make contact and prevent an impending suicide. Doctor, please give us your views on this about the media.
So basically, media is actually a power tool that can be used to create awareness regarding suicide, and it can actually, we can use it if used responsibly. We can use it for not only suicide awareness, but even talk about preventive methods of suicide. When a suicide happens, and important is that instead of sensationalizing the event, if the viewers are given accurate information about where to seek help, if they know of someone who is suicidal, or if they themselves are finding suicidal, if they themselves are if they themselves are suicidal, where to seek help. These can be used as opportunities to give people information. Then they can use these as opportunities to educate the public about mental illness, especially like depression, like substance use disorders, and also use them as opportunities to educate them regarding the available pathways and the available treatment. And it's also important to use these stories to focus on how to cope with life stresses, how to get help, where to get help, and positive measures that can be taken. What we don't want are copycat suicides. And copycat suicides are where basically the public use similar methods to commit suicide. So by avoiding placing stories repeatedly and glamorizing them in the media, using appropriate language, avoiding headlines, and also.
No, it's just that where we are concerned at Sumithrayo, we do our best to educate the media about it every year. In fact, try to have seminars for them and things like that. But they go back and do the same old thing. But I must say that there are some media that do give helplines at the bottom of their stories. Few and far between, but most of the media don't do that. And it's a very simple thing to do, just give the phone number and say, if anybody out there is struggling and needs help, please contact this number. So, okay,
Yes.
so thank you so much. Let me get into the next one. Doctor, this is about maternal suicide. Pregnancy and childbirth are usually described as periods of happiness in a woman's life. Unfortunately, it is also a time of increased vulnerability for mental health issues, and maternal suicide is increasing in Sri Lanka. Apart from the calamity of the loss of life of a mother, it inflicts significant negative health and socio-economic impacts on living children, the family, and community. Again, doctor, early identification, referral, and management of high-risk mothers can help reduce this tragic outcome. How can we establish an appropriate pathway to detect, refer, and manage pregnant and postpartum mothers with mental health disorders and those at risk of suicide? How can the community help?
There is actually a very well-established system in Sri Lanka. Our public health midwives visit our new mothers in the public sector, visit our new mothers, and they have been given a scale called the Edinburgh Postnatal Depression Scale, the EPDS, which is a highly sensitive tool to detect mothers who are depressed. And I must say our midwives do a fantastic job. And we get a lot of referrals from the midwives saying that this mother is possibly depressed or anxious or not coping well. And we see a lot of patients like that. Unfortunately, in the private sector, because the midwives don't visit for a lot of reasons. Some areas that is probably not as well covered. But definitely, if there is a midwife on assigned to a mother, that midwife is trained to detect and knows the appropriate referral system. There are again myths regarding pregnancy. So some earlier people believe that pregnancy is a protective factor when it comes to depression and suicide. That is a myth. During pregnancy, rates of depression do go up. Postpartum period, when a mother is depressed during the postpartum period, people think that this mother is feigning her symptoms or just pretending to be sad. Why is she sad? I mean, she has now a new baby, she's a mother, this new baby should be a bundle of joy. People can't comprehend why she could be depressed. But again, the postpartum period is a very high-risk period for depression, for psychosis, especially in a mother who was previously depressed. The chances of her becoming depressed again are very high during the postpartum period. 1 in 7 mothers will become depressed during the postpartum period. So that is how common it is. Postpartum depression, depression during pregnancy has to be seen by a mental health professional. And if it is of a moderate to severe nature, it has to be treated. It can't be ignored. What evidence tells us is if you ignore it, there can be consequences to the mother and the newborn baby. There is growth restriction, premature birth, premature delivery in mothers with mental illnesses. And when these mothers if they are treated, then all this can be avoided. So the community, I think as a community, we need to understand that that pregnancy and postpartum is a difficult period for any mother. It can be the first baby, second baby. And something that can be probably highlighted is that social support, supporting the mother during this period. It can be supporting her with domestic, when it comes to domestic issues, supporting her financial, whatever. Supporting the mother can actually not prevent, but help the mother get through this difficult period. Fortunately, in Sri Lanka, the grandparents step in when a baby is born. So our social support system is very good. Unlike the Western countries where when you are born, it's only the father and the mother of the baby, that's it. But here we have a nice extended family network. But as a community also, we need to be sensitive that this is a difficult time for the mother and that we need to kind of, step in and help when help is required.
Thank you, Doctor. But I have also read that when mothers have children with a very small window period apart, they find it extremely difficult to cope with both children, to navigate this. And if they do not have that support from the husband or, like you said, the grandparents or whatever it is, they can crash sometimes, and they can have depression because they are unable to cope with these two children. One child is probably 1.5 years old and the other is just born. So they find it very difficult and they feel guilty that they have not been able to, attend to their first child.
Lot of the difficulties, which again goes to show what a lot the community can do to, these are practical difficulties the mother is having. Sometimes the mother doesn't even have time to eat. The mother doesn't have time to sleep. When the baby sleeps, the mother is busy cooking, mopping the house, washing nappies.
Yeah.
So these are, you don't need to be any health professional to understand. All you need to do is kind of go and take some food for this mother, take some help with looking after the elder child. So small things that can go a long way.
Yes, Professor, thank you very much. I think what you said will open everybody's eyes, whoever is in here, about being sensitive to mothers who have given birth and who don't have a support system, to extend that support in some way and help them to cope with this new adventure they have started. Thank you very much. Doctor, another thing that I would like to bring up is something that is very rarely spoken about. It's about bereavement or grief due to suicide, which is experienced very differently from the mourning of a loss by natural causes. Because the stigma associated with suicide plays a big role, and family and friends find it difficult to reach out and unsure of what words of comfort should be offered. As a result, what scientists call a wall of silence is built by friends, family, and the community, who may discuss the suicide in hushed tones amongst themselves only. Survivors may go through feelings of guilt or blame that they were the cause and did not do the needful to prevent the suicide. They may choose to deal with it by denial or avoiding discussing it. If the grieving process is not allowed to proceed, some survivors may place themselves at risk for suicide. It is very important that the bereaved seek assistance, but the stigma often prevents them from seeking help. Doctor, your thoughts on this very important aspect of uh, survivors of suicide who have had a suicide in the family?
Okay, there is actually no easy way to learn about suicidal death. It's often unexpected. And even being an experienced clinician, when I get the news that somebody I have treated or somebody I knew from school or in my family, when I get that news, it's actually very difficult. Even after hearing lots of stories about suicide, especially when you have some attachment to that person, usually a very difficult thing to comprehend. Some people feel, if it is somebody in their family, they feel ashamed. Something that you will never feel if that person died of some other reason. If the person died of a heart attack, you're not going to feel ashamed. But see how unusual this is. You're feeling ashamed of a death. then some people actually feel angry. Why did he leave me? We had a beautiful family. We had money. We had support. Why did he leave us? And they're angry. When do we feel angry? When somebody dies of a heart attack, isn't it? So we kind of blame the person for dying. Then sometimes we feel guilty. Could I have prevented it? Is it that thing where I said that day that triggered him to do this? Is it the way I looked at him that day that triggered him to do this? Is it what I said, or is it what I didn't say? Could I have prevented it? That sense of guilt. And also that huge vacuum where, this person was there and it happened in front of me. Things were deteriorating in front of me and I couldn't do anything about it. So survivors of, people who have committed suicide, it's a very traumatic experience. And I myself I've known people, patients, friends who have committed suicide. It's still very difficult. And when we talk about media reporting also, we always say, don't go to question the family members over and over and over again. Don't interrogate them just to sensationalize your story. And it's a very, very difficult time.
Sometimes they even publish the notes left behind.
Exactly.
Which is a private thing.
Exactly. So as professionals, we have been trained because, it is a myth in psychiatry where any clinician can say, I have never had a suicide in my career. There is no such thing as zero suicide. Suicide is preventable, but unpredictable. You can do the best for certain patients, but still it can happen. But there are things that can alert us towards suicide, and we do our best, but sometimes it can be unpredictable. Well, in some countries, when a patient of yours commits suicide, there is actually therapy for the psychiatrist and the mental health team who have looked after the patient. In Sri Lanka, we turn to our colleagues for support. But we also have family members who have come to us looking for support, trying to manage their feelings. They have lots of questions. That is something I have observed. The why, the how, what else could I have done? And this is a long process. And as mental health professionals, I think what we can do is support them through that. There can be denial, there can be anger, there can be bereavement, and then finally a stage of acceptance and coming to terms with it.
Yes. I think that's also a time where places like Sumithrayo can offer that listening ear, in confidence, where they can call us up or walk in to see us and talk about their feelings in confidence. Even as an anonymous caller, they can do that. So I feel that the community at large should know this, and maybe even if you know of somebody who is in grief due to a suicide, they can give our phone number and say, why don't you call these people? Just give them a call and go and drop in and talk to them about your feelings. So I feel the more this kind of information disseminated, people will use it for their own support systems. Don't you think so, Doctor?
Yes, and remember in certain religions, suicide is looked down prohibited, and people from those backgrounds are unwilling to talk about it because of the shame, the guilt. So it is then there is a form of inhibited grief where they are unable to express their grief. And it is people like that who need a lot of help.
Yes. And also, Doctor, there's another thing where suicides are really kind of covered up and not at hospitals. They give other reasons, so that it is not documented as a suicide.
Yes.
And most often that affects the data that comes out finally, you know.
Yes.
So even the police sometimes do not document it as a suicide because they look at it in a different way.
Yes.
So, okay, thank you so much for those insights. Very valuable. Doctor, I'd like to talk to you about the trends of suicide, which I feel is very important. Uh, from the suicide statistics that are within our reach, we can see the following trends. That is, the male-female ratio is 4:1, which means that male are more prone to suicide than females, which we can discuss why. And 75% are married. 75% of people who take their lives are married. 50% are grade 1 to 8 educated. 30% O-level. 40% are aged 15 to 35. And 20% over 66 years, which is again a subject to talk about. 65% are unemployed. And 66% died by strangling. Doctor, your comments on these trends and how important it is to study suicide trends when formulating prevention strategies.
So important, isn't it? Because it is by looking at the trends that we can understand where to divert our finances, how to divert our finances, where to give more manpower, how to delegate services. All that is by understanding trends. And also, all this information you just gave is very important in the suicide risk assessment. If an elderly male comes to me with alcohol dependence, recently lost his job, feeling depressed or not taking his antidepressant medication, has a past history of deliberate self-harm, and now comes and tells me that I'm feeling suicidal, I would put that patient at very high risk. And I will need a very intensive management plan because of the risk. So the answer to your first question, how important is it to understand and to study suicide trends? It is by studying the suicide trends, especially with the Presidential Task Force in 1995, and by looking at the trends where about 30% of suicides were as a result of chemical poison by agrochemicals. And by banning WHO class 1 pesticides in 95, 96, 97, we saw a drastic drop in our suicide rate. What a fantastic thing. No, it was a community-based preventive measure. No psychiatrists were involved. Policymakers, stakeholders, agriculture minister, the minister.
Sumithrayo was also in it.
Sumithrayo, there you
task
go.
force.
There you go. And huge drop from 47 per 100,000 to,
now it's about 15
per 100,000. So there, it's a very, that is one of the proven methods of reducing suicide rates, limiting access to lethal methods, dangerous methods.
Yes.
So now we are seeing a downward trend in suicide rates, but now we are also seeing a upward trend in deliberate self-harm, where we are getting a lot of poison cases as a result of paracetamol overdose, prescribed medication, over-the-counter medication. So now people are arguing, okay, our suicide rates are going down, but we are also attempted increasing. So is it heralding another peak of suicides in the future? We don't know, but we know that there are a lot of people in distress.
Yes.
A lot of people who need intervention from a mental health point of view.
Yes.
Now it is a very interesting time for people who are studying suicide to study these trends in Sri Lanka.
Yes. Doctor, also I think the suicide rate of it coming down, where the deaths by suicide have becoming low, is because of the advancement in our health services.
Yes.
In our transport systems, in our roads, getting people to hospital fast.
Yes.
Compared to 1995, So
yes,
that is also, and also our first responders at the ETU, and they have been like trained, especially now, to be able to handle people who have attempted self-harm. So I think we should give credit to the health service also for bringing down that rate of deaths by suicide.
And establishing poison centers in that
Yes.
area. And also somebody was also mentioning, I mean, the increase in trishaws, three-wheelers in
getting them fast to the hospital.
Getting them fast to these hospitals and then attending to them. So all that has played a huge role.
Yes, definitely. So the thing is, the people whose lives have been saved, the data is really not collected. So we really don't know how many people have been saved. And so we can't understand really what the real situation is where the mental health towards and suicide is concerned, and why people want to take their lives or self-harm deliberately. Doctor, one more thing I'd like to talk to you about is that in 1984, Sumithrayo realized that with data at that time that about 30 to 35% of suicides were related to addiction. So that's how we started Malmadura, which we are still running at the same time. I also read some research, little bit of research has been done where they have done psychological autopsies of suicides in certain areas in Sri Lanka, like Kurunegala and all that, and found that in one place, they have found that 60% of attempted suicides and suicides had alcohol in their bloodstream.
Yes.
So because alcohol makes them impulsive,
And no, and also having alcohol dependence is an independent risk factor for suicide. 7% of patients with alcohol dependence will commit suicide. Remember, 7 out of 100, that's a huge amount.
Yeah, it is.
Okay. And alcohol paves the way to other mental disorders like depression, anxiety, delusional disorders, morbid jealousy, sexual disorders, and all these can independently play a role in as a risk factor for suicide. And in a country like Sri Lanka, they have shown a very strong relationship between alcohol use and suicide.
So they call that a little triangle of someone in distress having access to alcohol and also having access to a plan or a method to take their lives after the alcohol, because it makes them impulsive and not rational, probably, especially after these fights, doctor, in the rural areas, especially when there are domestic fights between husband and wife, maybe that's the time, and if there's alcohol in the system, they kind of, either in the 1990s, it was taking the poison or the insecticide. Now it's probably hanging themselves, which is very high at the moment.
Yeah, now hanging has taken over pesticide poisoning. That's right.
Strangling. Yes. So, Doctor, now it's almost 7 o'clock, and we have, I think, one question which I would like to. Can I read that out to you?
Yes, please.
One thing I recently heard is people who are working on helping people who are suicidal are those who are more vulnerable towards suicide. Therefore, they try to support others like a defense mechanism. Is that true or a myth? It's a very interesting question, really.
I lost the last bit of the question.
Okay, I'll read it out to you again.
Okay.
One thing I recently heard is people who are working on helping people who are suicidal are those who are more vulnerable towards suicide. Therefore, they try to support others like a defense mechanism. Is that true or a myth? Actually, it's a very interesting question.
Very interesting. It's like this. People who are very psychologically minded, people who are sensitive towards the emotional health towards others, and people, so who are basically psychological minded, are more attracted to the field of psychology. These are also the same people who are able to understand their own emotional health. There are actually people who are unaware that they are nasty people, that they are anxious people. They don't have that emotional intelligence to understand that.
Okay, I understand.
So when you know that you are suffering or that you're feeling sad, when you have gone through that, you are able to empathize with similar people. And as a result, you are attracted towards helping such people. So the answer to that question is, well, yes, in a way, people who are more psychologically minded are able to understand their own emotions and as well as the emotions of others. As a result of you understanding your emotions and understanding the suffering behind those emotions, you're able to understand the suffering of others and you're able to help other people as a result of that. It may be a sense or it may be a defense mechanism also, but it also can be a very healthy defense mechanism where you can, it's where you know how, what helped you, how you overcame it, and you can use that to help another person.
Thanks, Doctor. I think that's a very good way of looking at it. Although the question was a very good question, but you navigated it very well. Now, the fact that there are no other questions is actually a compliment to you, because it means that you have explained everything very lucidly. And I hope you don't take it wrongly that there are no more questions, because I think there's been no need to ask questions because you have been very, very clear in the way you have answered and spoken about suicide. So thank you so much. It was a real pleasure talking to you.
You too.
And we hope we can meet you again somewhere on Zoom.
All the best.
Sumithrayo.
All the best to Sumithrayo, and thank you for all the wonderful work.
Thank you for being with us today, and have a good night.
Good night.